Hepatic cirrhosis. Definition. Hepatic cirrhosis is a disease in which healthy liver tissue is replaced with scar tissue. The scar tissue blocks the flow of blood through the liver and slows the liver's ability to process nutrients, hormones, drugs, and natural toxins. Cirrhosis is a complication of many liver diseases characterized by abnormal structure and function of the liver. The diseases that lead to cirrhosis do so because they injure and kill liver cells, after which the inflammation and repair that is associated with the dying liver cells causes scar tissue to form. The liver cells that do not die multiply in an attempt to replace the cells that have died. This results in clusters of newly formed liver cells, regenerative nodules, within the scar tissue. The end stage of liver disease is called cirrhosis. Hepatic cirrhosis is a chronic hepatic disease characterized by diffuse destruction and fibrotic regeneration of hepatic cells. As necrotic tissue yields to fibrosis, this disease alters liver structure and normal vasculature, impairs blood and lymph flow, and ultimately causes hepatic insufficiency. Statistics and incidences. Various types of cirrhosis may occur in different types of individuals. The most common, Leydig cirrhosis, occurs in 30% to 50% of cirrhotic patients. Biliary cirrhosis occurs in 15% to 20% of patients. Post-necrotic cirrhosis occurs in 10% to 30% of patients. Pigment cirrhosis occurs in 5% to 10% of patients. Idiopathic cirrhosis occurs in about 10% of patients. Classification. These clinical types of cirrhosis reflect its diverse etiology. Leydig cirrhosis. The most common type, this occurs in 30% to 50% of cirrhotic patients, up to 90% of whom have a history of alcoholism. Biliary cirrhosis. Biliary cirrhosis results in injury or prolonged obstruction. Post-necrotic cirrhosis. Post-necrotic cirrhosis stems from various types of hepatitis. Pigment cirrhosis. Pigment cirrhosis may result from disorders such as hemochromatosis. Cardiac cirrhosis. Cardiac cirrhosis refers to cirrhosis caused by right-sided heart failure. Idiopathic cirrhosis. Idiopathic cirrhosis has no known causes. Common causes of cirrhosis of the liver include alcohol, non-alcoholic fatty liver disease, cryptogenic causes, chronic viral hepatitis A, B, and C, autoimmune hepatitis, inherited, genetic disorders, primary biliary cirrhosis, PCB, primary sclerosing cholangitis, PSC, infants born without bile ducts. Less common causes of cirrhosis include unusual reactions to some drugs, prolonged exposure to toxins, chronic heart failure, cardiac cirrhosis. In certain parts of the world, particularly Northern Africa, infection of the liver with a parasite, schistosomiasis, is the most common cause of liver disease and cirrhosis. Stages of cirrhosis of the liver. Stage 1 cirrhosis involves some scarring of the liver, but few symptoms. This stage is considered compensated cirrhosis, where there are no complications. Stage 2 cirrhosis includes worsening portal hypertension and the development of varices. Stage 3 cirrhosis involves the development of swelling in the abdomen and advanced liver scarring. This stage marks decompensated cirrhosis, with serious complications and possible liver failure. Stage 4 cirrhosis can be life-threatening and people have developed end-stage liver disease, ESLD, which is fatal without a transplant. Pathophysiology. Clinical manifestations. Clinical manifestations of the different types of cirrhosis are similar, regardless of the cause. GI system. Early indicators usually involve gastrointestinal signs and symptoms such as anorexia, indigestion, nausea, vomiting, constipation, or diarrhea. Respiratory system. Respiratory symptoms occur late as a result of hepatic insufficiency and portal hypertension, such as pleural effusion and limited thoracic expansion due to abdominal ascites, interfering with efficient gas exchange leading to hypoxia. Central nervous system. Signs of hepatic encephalopathy also occur as a late sign, and these are lethargy, mental changes, slurred speech, asterixis, flapping tremor, peripheral neuritis, paranoia, hallucinations, extreme obtundation, and ultimately, coma. Hematologic. The patient experiences bleeding tendencies and anemia. Endocrine. The male patient experiences testicular atrophies, while the female patient may have menstrual irregularities, and gynecomastia and loss of chest and axillary hair. Skin. There is severe pruritus, extreme dryness, poor tissue turgor, abnormal pigmentation, spider angiomas, palmar erythema, and possibly jaundice. Hepatic cirrhosis causes jaundice, ascites, hepatomegaly, edema of the legs, hepatic encephalopathy, and hepatic renal syndrome. Assessment and diagnostic findings. History taking. Physical examination. Liver function test. Liver scan. Liver scan shows abnormal thickening and a liver mass. Liver biopsy. Liver biopsy is the definitive test for cirrhosis as it detects destruction and fibrosis of the hepatic tissue. Liver imaging. Computed tomography scan, ultrasound, and magnetic resonance imaging may confirm the diagnosis of cirrhosis through visualization of masses, abnormal growths, metastases, and venous malformations. Cholecystography and cholangiography. These two visualize the gallbladder and the biliary duct system. Splenoportal venography. Splenoportal venography visualized the portal venous system. Percutaneous transhepatic cholangiography. This test differentiates intrahepatic from extrahepatic obstructive jaundice and discloses hepatic pathology and the presence of gallstones. Complete blood count. There is decreased white blood cell count, hemoglobin level and hematocrit, albumin, or platelets. Medical management. Treatment is designed to remove or alleviate the underlying cause of cirrhosis. Diet. The patient may benefit from a high-calorie and a medium to high-protein diet, as developing hepatic encephalopathy mandates restricted protein intake. Sodium restriction is usually restricted to 2 g day. Fluid restriction. Fluids are restricted to 1 to 1.5 liters day. Activity. Rest and moderate exercise is essential. Paracentesis. Paracentesis may help alleviate ascites. St. Steken-Blakemore or Minnesota tube. The St. Steken-Blakemore or Minnesota tube may also help control hemorrhage by applying pressure on the bleeding site. Pharmacologic therapy. Drug therapy requires special caution because the cirrhotic liver cannot detoxify harmful agents effectively. Octreotide. If required, octreotide may be prescribed for esophageal varices. Diuretics. Diuretics may be given for edema, however, they require careful monitoring because fluid and electrolyte imbalance may precipitate hepatic encephalopathy. Lactulose. Encephalopathy is treated with lactulose. Antibiotics. Antibiotics are used to decrease intestinal bacteria and reduce ammonia production, one of the causes of encephalopathy. Surgical management. Surgical procedures for management of hepatic cirrhosis include transjugular intrahepatic portosystemic shunt, TIPS, procedure. The TIPS procedure is used for the treatment of varices by upper endoscopy with banding to relieve portal hypertension. Liver transplantation. Nursing management. Nursing management for the patient with cirrhosis of the liver should focus on promoting rest, improving nutritional status, providing skin care, reducing risk of injury, and monitoring and managing complications. Nursing assessment. Assessment of the patient with cirrhosis should include assessing for bleeding. Check the patient's skin, gums, stools, and vomiters for bleeding. Fluid retention. To assess for fluid retention, weigh the patient and measure abdominal girth at least once daily. Mentation. Assess the patient's level of consciousness often and observe closely for changes in behavior or personality. Nursing diagnosis. Based on the assessment data, the major nursing diagnoses for the patient are activity intolerance related to fatigue, lethargy, and malaise. Imbalanced nutrition, less than body requirements related to abdominal distension and discomfort and anorexia. Impaired skin integrity related to pruritus from jaundice and edema. High risk for injury related to altered clotting mechanisms and altered level of consciousness. Disturbed body image related to changes in appearance, sexual dysfunction, and role function. Chronic pain and discomfort related to enlarged liver and ascites. Fluid volume excess related ascites and edema formation. Disturbed thought processes and potential for mental deterioration related to abnormal liver function and increased serum ammonia level. Ineffective breathing pattern related to ascites and restriction of thoracic excursion secondary to ascites, abdominal distension, and fluid in the thoracic cavity. Nursing care planning and goals. The major goals for a patient with cirrhosis are: report decrease in fatigue and increased ability to participate in activities. Maintain a positive nitrogen balance, no further loss of muscle mass, and meet nutritional requirements. Decrease potential for pressure ulcer development and breaks in skin integrity. Reduce the risk of injury. Verbalize feelings consistent with improvement of body image and self-esteem. Increase level of comfort. Restore normal fluid volume. Improve mental status, maintain safety, and ability to cope with cognitive and behavioral changes. Improve respiratory status. Nursing interventions. The patient with cirrhosis needs close observation, first-class supportive care, and sound nutrition counseling. Promoting rest. Position bed for maximal respiratory efficiency, provide oxygen if needed. Initiate efforts to prevent respiratory, circulatory, and vascular disturbances. Encourage patient to increase activity gradually and plan rest with activity and mild exercise. Improving nutritional status. Provide a nutritious, high-protein diet supplemented by B-complex vitamins and others, including A, C, and K. Encourage patient to eat, provide small, frequent meals, consider patient preferences, and provide protein supplements, if indicated. Provide nutrients by feeding tube or total PN if needed. Provide patients who have fatty stools, steatorrhea, with water-soluble forms of fat-soluble vitamins A, D, and E, and give folic acid and iron to prevent anemia. Provide a low-protein diet temporarily if patient shows signs of impending or advancing coma. Restrict sodium if needed. Providing skin care. Change patient's position frequently. Avoid using irritating soaps and adhesive tape. Provide lotion to soothe irritated skin. Take measures to prevent patient from scratching the skin. Reducing risk of injury. Use padded side rails if patient becomes agitated or restless. Orient to time, place, and procedures to minimize agitation. Instruct patient to ask for assistance to get out of bed. Carefully evaluate any injury because of the possibility of internal bleeding. Provide safety measures to prevent injury or cuts, electric razor, soft toothbrush. Apply pressure to venipuncture sites to minimize bleeding. Monitoring and managing complications. Monitor for bleeding and hemorrhage. Monitor the patient's mental status closely and report changes so that treatment of encephalopathy can be initiated promptly. Carefully monitor serum electrolyte levels are and correct if abnormal. Administer oxygen if oxygen desaturation occurs. Monitor for fever or abdominal pain, which may signal the onset of bacterial peritonitis or other infection. Assess cardiovascular and respiratory status. Administer diuretics. Implement fluid restrictions, and enhance patient positioning, if needed. Monitor intake and output, daily weight changes, changes in abdominal girth, and edema formation. Monitor for nocturia and, later, for oliguria, because these states indicate increasing severity of liver dysfunction. Home management. Prepare for discharge by providing dietary instruction, including exclusion of alcohol. Refer to Alcoholics Anonymous, psychiatric care, counseling, or spiritual advisor if indicated. Continue sodium restriction, stress avoidance of raw shells. Provide written instructions, teaching, support, and reinforcement to patient and family. Encourage rest and probably a change in lifestyle, adequate, well-balanced diet and elimination of alcohol. Instruct family about symptoms of impending encephalopathy and possibility of bleeding tendencies and infection. Offer support and encouragement to the patient and provide positive feedback when the patient experiences successes. Refer patient to home care nurse and assist in transition from hospital to home. Evaluation. Expected patient outcomes include reported decrease in fatigue and increased ability to participate in activities. Maintained a positive nitrogen balance, no further loss of muscle mass, and meet nutritional requirements. Decreased potential for pressure ulcer development and breaks in skin integrity. Reduced the risk of injury. Verbalized feelings consistent with improvement of body image and self-esteem. Increased level of comfort. Restored normal fluid volume. Improved mental status, maintained safety, and ability to cope with cognitive and behavioral changes. Improved respiratory status. Discharge and home care guidelines. The focus of discharge education is dietary instructions. Alcohol restriction. Of greatest importance is the exclusion of alcohol from the diet, so the patient may need referral to Alcoholics Anonymous, psychiatric care, or counseling. Sodium restriction. Sodium restriction will continue for considerable time, if not permanently. Complication education. The nurse also instructs the patient and family about symptoms of impending encephalopathy, possible bleeding tendencies, and susceptibility to infection. Complications. Swelling of the abdomen, ascites, and/or in the hip, thigh, leg, ankle, and foot. Spontaneous bacterial peritonitis. Bleeding from varices. Hepatic encephalopathy. Hepatorenal syndrome. Hepatopulmonary syndrome. Hypersplenism. Portal hypertension. Esophageal varices. Liver cancer.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.